How's everybody doing today? Hope you had a great weekend. My name's Bill Schroeder. Some of you already know that. We appreciate all our subscribers to the Virtual Vascular Lab YouTube channel. You know what day it is. Technical Tip Tuesday. Well, all the teaching that we do for vascular ultrasound, we find probably the #1 source of error is improper Doppler angle correction, leading to an incorrect velocity. Probably the second most frequent error we see is the use of velocity to define disease. And this is really an incorrect application of the technology. That's what I'm going to talk to you about today. Hope you enjoy. Just a quick overview of duplex ultrasound and why it's so great for evaluating the vascular system. We get the anatomy, we can see any pathology, we also get physiology, and of course then if there is pathology, we can appreciate the pathophysiology. Pretty great stuff. So here's the bottom line. Our velocity calculation does not define disease. The velocity helps us categorize the severity of the disease. So this is really how you detect the presence of disease. First off, you have the image. Can you visualize disease in the image? If not, there's probably not significant disease there, regardless of your velocity calculations. If there is, we know that stenoses abide by hemodynamic principles. That is, can we detect a flow acceleration at that area of narrowing? Is there post-stenotic flow pattern? We may get altered flow proximal and/or distal depending on the severity. Make sure this entire picture is present. We want to always explain all Doppler changes with imaging, otherwise they become suspect. Beware the image Doppler mismatch. If they're not all telling you the same thing, something's probably missing. So in order to determine if hemodynamically significant stenosis is present, you have to document what we term the stenosis profile. That is, proximal to the stenosis, flow may be dampened depending on its severity and how close to that stenosis you're taking your sample from. Within the stenosis, we're going to see spectral broadening, a disturbed flow, elevated frequencies, and hence elevated calculated velocities. Then, most important too, is to document the presence of post-stenotic turbulence with the flow reversals, eddy currents, vortices. Basically, that post-stenotic turbulence is integral to the determination of a stenosis. Let's look at an example. Here's a nice popliteal artery stenosis. I've actually had this on my computer for many years. We can see disease in the image. We see a narrowing of the color flow channel. We see focal flow acceleration, disturbed flow distal to the stenosis. Let's look at a spectral waveform. Dampened flow proximal, low peak systolic velocity, 42 centimeters per second. Dramatic elevation within the stenosis, 326 centimeters per second. Focal flow acceleration. So what other element do we need? Absolutely right. Post-stenotic turbulence. The picture is not complete unless you document post-stenotic turbulence. So if we go far enough distal to that stenosis, depending on its severity, we may see a dampened waveform because of the energy losses through that stenosis. So in summary, we can use velocity criteria to categorize a stenosis of greater than 50%. We know in lower extremity arteries, a 2-to-1 velocity increase through that stenosis has been validated to demonstrate a greater than 50% stenosis. 4-to-1 velocity ratio, greater than 75% stenosis. Velocity does not, however, determine the presence of disease. We do that with imaging. And velocity also does not define normalcy. If there's any plaque, it is not normal. So I hope you enjoyed this little short tutorial on using velocity to help categorize disease. Remember, categorize, not define. If you enjoyed it, like, subscribe, give us some comments. If you need any CME, please visit us at virtualveincenter.com. See you next week.